First, we will be talking about urinary tract infections more broadly. Urinary tract infections, or UTIs for short, are inflammation of the urinary epithelium. Oftentimes, it's caused by bacteria, usually from the skin or gut, entering the urethra and infecting the urinary tract. Infection can occur anywhere along the urinary tract. Involvement of the urethra and bladder oftentimes is thought of as a lower urinary tract infection, whereas if it gets up to the kidneys, that's considered an upper urinary tract infection and it is more serious. So UTIs can be broken down into where the infection happens specifically, with the most common type being bladder infection, which is termed cystitis, and less common but more serious, as I mentioned earlier, is a kidney infection or pyelonephritis. Also on this slide, you can see infecting microorganisms, with the two most common infecting microorganisms being E. coli and S. saprophyticus. The risk factors for UTI include factors increasing urinary stasis, such as obstruction, urinary retention, and renal impairment, foreign bodies, such as kidney stones and catheter insertion, factors compromising immune response, such as diabetes, HIV infection, and other factors, estrogen deficiency in postmenopausal women, pregnancy, multiple sex partners, poor hygiene, and delay of urination, sometimes called nurse's bladder. And men to UTIs. Anatomically speaking, they have shorter urethras and a urethral opening that's very close to the anus, which increases the chances of bacterial contamination from the gut. Since men, generally speaking, are less likely to develop a UTI, when they end up being diagnosed with this, an ultrasound is indicated to rule out likelihood of kidney stones, stricture formation, or the presence of a tumor, or any other factor that could be promoting urinary stasis and, as a result, the development of a urinary tract infection. A UTI occurs when a pathogen circumvents or overwhelms the host's defense mechanisms and rapidly reproduces. First, colonization of the urethra, where the pathogen colonizes the periurethral area and descends through the urethra towards the bladder. Next, penetration of the uroepithelial layer. Fimbria allow bladder epithelial cell attachment and penetration. Following this, the bacteria continue to replicate and may form biofilms. Once sufficient bacterial colonization has occurred, the bacteria may begin to ascend on the ureters and eventually reach the kidneys. Bacterial toxins also play a role in aiding the ascension process by inhibiting peristalsis and, as a result, reducing urine flow, which helps with flushing out bacterial organisms. Once microorganisms reach the kidneys, this is considered pyelonephritis. Infection of the renal parenchyma causes an inflammatory response. While the infection is usually the result of the bacterial ascension, it also occurs through hematogenous spread. And finally, acute kidney injury, where if the inflammatory cascade does continue, there's tubular obstruction and damage that occurs, leading to interstitial edema, and this is what could lead to interstitial nephritis, causing acute kidney injury, AKI. Diagnostic tests include urinalysis, urine culture, and imaging. The urinalysis helps confirming the presence of a UTI. Urine culture specifies what microorganisms have colonized the urinary tract. Ultrasound of the genitourinary organs aids providers in visualizing the kidneys, bladder, and other structures. Treatment modalities follow antibiotics, pain management, and education on how clients can reduce the risk of developing another UTI, complications, especially when the UTI is left untreated, are pyelonephritis, kidney injury, sepsis, and anemia. Let's talk about acute cystitis. It is defined as an inflammation of the bladder and is the most common site of UTI. The usual colonizing microorganisms include E. coli and S. saprophyticus, as mentioned earlier. And while fungal infections are much less common, they will usually be seen in immunosuppressed individuals. The morphological appearance of the bladder can be seen through a cystoscope, and this is what determines the type of cystitis is in play. Mild cystitis, you'll see that the mucosa is red or hyperemic. In hemorrhagic cystitis, you'll see some diffuse hemorrhage, and in suppurative cystitis, you'll see the formation of pus. Pay extra attention to clinical manifestations and the more serious signs and symptoms of cystitis. Normally, frequency, urgency, dysuria, and suprapubic or lower back pain are what you will see in someone suffering from cystitis. More serious signs and symptoms, however, are hematuria, cloudy and foul-smelling urine, and flank pain, which could be indicative of upper UTI. In older adults, it's worth noting that symptoms could be vague, including abdominal discomfort and confusion, or the older adult may be asymptomatic and feel nothing at all. Diagnosis is done with urine culture, which will show 10,000 or more counts per milliliter of microorganisms in the urine, and a urine dipstick that is positive for leukocyte esterase or nitrite reductase. Treatment for all UTIs really is done with antibiotics. However, resistance is an emerging problem, so there's a lot of teaching too that needs to be done with prescription of antibiotics. Normally, for uncomplicated UTI, this will involve 3 to 5 days of antibiotic treatment. With complicated UTIs, 7 to 14 days of treatment, followed up by cultures a week after initiation of treatment, and then at monthly intervals for 3 months following. Clinically, at this point, symptoms may be relieved, but usually bacteriuria will still be present. Cultures are to be repeated every 3 to 4 months until a year after treatment was started for the valuation of recurrent infection. Interstitial cystitis, or painful bladder syndrome. It's an unpleasant sensation perceived to be related to urinary bladder, lasting 6 or more weeks in the absence of infection or other identifiable causes. While the etiology is mostly unknown, it's thought to be as a result of an autoimmune response. Normally, characteristic signs and symptoms are bladder fullness, frequency, and or small urine volume, and chronic pelvic pain. Diagnosis is done with a very thorough history and physical, along with urinalysis and cystoscopy. Treatment involves oral and intravesical therapy, sacral nerve stimulation, and sometimes even Botox. These are all done for symptom relief and management. For refractory cases, surgery will be indicated. Moving on to upper respiratory tract infections, we have acute pyelonephritis. It is an infection of one or both upper urinary tracts Most common underlying risk factors being urinary obstruction and urine reflux from the bladder. Microorganisms include E. coli, Proteus, and Pseudomonas, with the latter two infections being common following urethral instrumentation or surgery. These microorganisms make urine alkaline and do increase the risk of stone formation, which is another factor that can obstruct urine flow. Infection does spread by ascending ureters or traveling via bloodstream, which was mentioned before, and it involves focal and irregular inflammation, with severe cases showing abscess and necrosis, and following an acute phase, when the kidneys do start to heal, there will be scar tissue formation, fibrosis, and atrophy. In acute pyelonephritis, however, renal failure is rare, with clinical manifestations being more systemic and involving acute onset of fever, chills, accompanied by flank or groin pain, and non-specific symptoms in older adults, which could include low-grade fever and malaise. In evaluating and diagnosing acute pyelonephritis, a urine culture and urinalysis will be done. White blood cell casts present in the urine are indicative of acute pyelonephritis. However, they are not always present. Blood culture and urinary tract imaging is sometimes indicated in complicated pyelonephritis. IV pyelography and voiding cystourethropy help with identifying any surgically correctable lesions. In terms of treatment, if it's uncomplicated acute pyelonephritis, 2 to 3 weeks of microorganism-specific antibiotic therapy is effective, with follow-up urine cultures 1 to 4 weeks after treatment should symptoms recur. Again, antibiotic-resistant microorganisms or reinfection may occur if there is urinary obstruction or reflux present. Chronic pyelonephritis is a persistent or recurrent infection of the kidney, leading to scarring. One or both kidneys may be involved. Causes are sometimes idiopathic or unknown, but there is strong association with chronic UTIs, vesico-ureteral reflux, renal stones, obstructive uropathy, and recurrent infection from acute pyelonephritis. So it's worth noting that earlier I did mention acute pyelonephritis rarely leads to kidney failure. However, if acute pyelonephritis continues and recurs, this promotes the chronic obstruction of the genitourinary tract, which prevents free bacterial elimination through urine. A condition of progressive inflammation, which in turn promotes either atrophy or dilation and diffuse scarring that impairs urine concentrating ability and ultimately leads to chronic kidney failure. In pathophysiology, you can see too that there are lesions that develop located in the interstitial spaces between renal tubules, and this is referred to as chronic interstitial nephritis. In chronic pyelonephritis, early signs and symptoms include frequency, dysuria, flank pain, and hypertension. Later manifestations are renal failure, inability to conserve sodium, loss of tubular function, hyperkalemia, metabolic acidosis, and dehydration. Diagnosis and evaluation is through urinalysis, IV pyelography, and ultrasound. Treatment, as with most UTIs, is done with antibiotics, pain management, but in terms of chronic pyelonephritis, there's also a focus on relieving whatever source of obstruction there is and treating underlying causes.